This is Breakthroughs, a podcast from Northwestern University Feinberg School of Medicine. I'm Erin Spain, executive editor of the Breakthroughs newsletter. Breast cancer survival rates have been improving since the 1990s, but there's still a significant need for new therapies. Every year, more than 40,000 American women die from breast cancer. Dr. Massimo Cristofanilli is here with some exciting results from a Phase 3 clinical trial published in the New England Journal of Medicine that shows improved survival rates for women with common forms of advanced breast cancer. He is the Associate Director of Translational Research here at the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. Thank you for your time today.
Thank you for having me.
So October is Breast Cancer Awareness Month, and experts like you are going all over the country presenting new findings, attending conferences. And I'm curious, what is the state of breast cancer today in America, in the world?
Breast cancer is one of the diseases where we have really made major strides against, particularly due to the fact that there's been a lot of funded research. So understanding the biology of the disease, applying appropriate technology to discover the molecular drivers, and particularly having new drugs to treat the advanced form of breast cancer. Some of these drugs, of course, made it all the way back to the early disease. So we have seen a dramatic improvement in survival for a number of reasons. We know the early detection has an impact. We know also that improving the management in the adjuvant setting after primary surgery has an impact. At this point, we are even de-escalating chemotherapy from patients that do not need, because we better understand which patients have a more aggressive disease. In advanced disease, patients with metastatic breast cancer, no doubt, live much longer with no symptoms. This is due primarily, as I mentioned, to the understanding of the disease and the availability of new drugs that we can offer to our patients.
But there's still work to be done.
Yes, as you mentioned, 40,000 women are still dying of advanced breast cancer. Many of these women have aggressive treatment-resistant disease, and they're younger than they used to be. So this is an obligation really to experiment even more and to find better treatments. And I can tell you that our major focus now is for triple negative, for younger women. Having drugs that improve survival is a very difficult and challenging goal for every new drug. In fact, most of the drugs that we have available in breast cancer are being approved primarily because they prolong the disease control, what is called the progression-free survival. And very few, if any, show a survival advantage in women that have been treated with a specific type of drug. So I think that's the reason why we are excited about this data.
You said that women seem to be younger now, the diagnosis. Why is that?
Well, there is, I think, a number of factors. Of course, the disease can be based on genetic predisposition. We know that BRCA1 and BRCA2 and some other predisposition gene put the women at risk of developing breast cancer at an early age, and these tumors are naturally more aggressive and sometimes resistant to standard treatments. Some disease subtypes are more common in African American women, naturally also in younger African American women, and they don't have always the ability to access new care and new treatments. And certainly there is a biology that we don't understand yet. There could be a number of other factors that contribute to the disease become aggressive, even if it's estrogen positive in younger women.
So you mentioned estrogen positive. Could you just go through some of the different most common types of breast cancer and how they're treated today?
Sure. So the three primary markers that we use in understanding and dividing the type of breast cancer are estrogen, progesterone, and HER2 oncogene as protein expression. Once we have stained the primary tumors with this particular three different immunohistochemical staining, we divide this breast cancer in three different subtypes. More generic, the luminal subtype, the estrogen-positive tumors, the triple-negative subtype, negative for all three, and the HER2-positive subtypes. These are important implications in terms of treatments. If you talk about primary tumor that was just diagnosed, most of the patients will have surgery, plus or minus radiation, depends on the size of the tumor, other factors. May receive chemotherapy after, particularly for the triple-negative or the HER2-positive. With the HER2-positive together with antibodies targeting the HER2 proteins. And the patient with ER-positive have a special group. and actually the most challenging in some cases, because some of them will not need chemotherapy because they are less aggressive. Some other are more aggressive, and in spite of chemotherapy and endocrine therapy, they may have a recurrence over the years. And sometimes these recurrences are also late, after 5 years. So we definitely have this estrogen-positive subset or luminal subset as the major area of development because it's the most common. More than 60-65% of the patients with breast cancer have an estrogen-positive tumor. So as I mentioned, they receive primary therapy, and at some point they may have a recurrence. So for us, developing new drug for estrogen-positive tumor that have a recurrence is an important task because these are the drugs that are going to affect the majority of patients with breast cancer, likely contribute to decrease mortality and improve survival.
And these are the women who are involved in the clinical trial Paloma 3 that you just have these results that have been published. Tell me a little bit about these women. Why didn't they respond? Why was there a relapse?
So I was mentioning that patients with primary breast cancer start to take a pill, an endocrine therapy, after they finish surgery, sometimes chemotherapy. And they take this agent for controlling the disease, the micrometastatic disease, for at least 5 years. During this time, though, some of the cells may become resistant, and the tumor can come back in very common sites like the bone, lymph nodes, or other organs. In some cases, so this recurrence happens earlier, and the patient started a new treatment that is still an endocrine therapy, and if they don't respond, they need to move on to other therapies. So the Paloma 3 was a study that was designed for patients who were premenopausal or postmenopausal, and they have failed one of these agents, either where they were taken after surgery for adjuvant purpose or after they have recurred in a metastatic setting. That's what obviously a challenging situation. So they have become endocrine resistant, and we wanted to prove that if you were to take in this new drug, palbociclib, together with the common second-line endocrine therapy, the drug was effective in prolonging the disease control compared to the other single-agent drug, the fulvestrant alone. So the study was already published in the first endpoint. The first and primary endpoint was to prolong the progression-free survival. And this was the first data were published in the New England Journal in 2015. And we saw that the drug was effective, was well tolerated, and there was an improved response. All the signs were associated with major benefit, so it was approved by the FDA, and it was an extended label. We continue to follow these patients, and we wait a number of events, a number of women that have somewhat progressed and eventually fail every therapy. So now we have the data regarding the survival of this patient in the two arms of the treatment. The one that received the palbociclib, we know for how long they continue on the palbociclib treatment, what happened after that, eventually how they're doing, and for the other arm as well. So we have the ability to tell what the palbociclib did to the overall disease over time. A median follow-up of this patient was 44.8 months, so a relatively long time. So this is the first report that we have with regard to the overall survival, not only for the palbociclib, for a phase 3, but for every phase 3 that was done in this particular population with this class of drugs. All the other studies are not mature enough to have an overall survival data. So the study enrolled 521 patients. They were randomized in two groups. We say this is a randomization 2-to-1, so the majority of patients received the active combination compared to the single agent arm with placebo. And they were stratified based on the fact that they had progressed after a long time from a prior endocrine therapy, or they have responded to the first line of therapy. We would define this endocrine sensitive, even though they have progressed. And the other group was defined endocrine insensitive. And we were looking at other secondary endpoints. So we knew that the study was not large enough to be able to answer the question with regard to the overall survival. So this was a secondary endpoint. The primary endpoint was still looking at the progression-free survival.
Okay, so you knew that the drug was effective, but now how does it impact survival? How much longer can these women, their survival rate?
Right, and this is, as I mentioned, is a very challenging endpoint for every study in metastatic disease, in particular for this patient with endocrine therapy, because they receive multiple lines of therapy, other drugs after. So we look at this, and we were able to essentially demonstrate, that's what the data show, that with this 44.8 months of follow-up, there is a difference, an absolute difference, almost 7 months in survival between the two groups.
Between the people that got the placebo versus the ones that got
Correct. So the group of patients that received the medication had a median overall survival at 34.9 months compared to 28 months. And this is remarkable, as I said. The other endpoint that we look at, because as I mentioned, there was a stratification to look at who would benefit the most. Essentially, the majority of patients would benefit, but the patients that benefit the most were the ones that at some point have shown response to the endocrine therapy. So they were not completely refractory to endocrine therapy. In this group of patients, the overall survival difference was 10 months. So very remarkable, very statistically significant. The median overall survival for the group of patients that received the drug was 39.7 months. So we're talking about metastatic disease. You see that there are patients that go well over the standard survival that we know and recommend to patients. And the fulvestrant was 29.7 months. Not only that, we also measure a number of other endpoints. So for how long the medication was assumed by the patient, for how long they stay in the drug. So patients that were taking palbociclib were taking this medication for a median of 11 months compared to only 4.6 months. This means that if you were treated just with the endocrine therapy, shortly after you start, just a little bit more than 4 months, you had to stop that and think about a new treatment. And this new treatment was most of the time chemotherapy. And you were going from one treatment to another because there was not a very effective drug at that point. And this was, instead, the group of patients treated with palbociclib, it was a median of 17.6 months before they were to go to chemotherapy, compared to 8.8 months. So these women had the normal life for much longer time. Not only their survival was prolonged, but their quality of life was improved. And this was measured very carefully in the study. It was published in prior study. We showed these women had symptoms improvement, their mood was better, they didn't have major side effects. So imagine taking chemotherapy requires a number of measures. Chemotherapy makes you sick, chemobrain, white count, risk of infection, and so forth. So I think it's relevant to consider and putting everything in the right perspective that you have a prolongation of quality survival. And then we look at also the type of treatment that every patient receive after, and the patient continue to respond to the next treatment without having any impact from the prior treatment. So in essence, this is a meaningful clinical survival improvement because we improve different measures of life, quality of life. Patients were delaying the chemotherapy, were staying on the drug for a longer time, and when they start the next treatment, they continue to respond to the next treatment. So that's one of the reasons why we think this is a remarkable result. We set the new standard. We would like to have every drug from now on that have such an impact on overall survival like palbociclib did.
Yeah, this is pretty much the gold standard when it comes to clinical trials to get to this phase 3 and then to have results like this. What has been the response from your colleagues in the community who have heard of these results?
The majority of clinicians feel very strongly about using this drug already, and they feel that they are now certainly on the right direction when they see this data, supporting the use of this drug in this refractory resistant disease setting. Of course, patients and patient advocates would be extremely happy about this because I think this is one of the first few times where a drug in metastatic setting shows a survival advantage. So who would not like to see this without major side effects? The purist people that are a little bit more into the details of statistics will think that this, because we have not reached officially the statistical significance in the overall population, maybe we needed to have a larger study to really confirm it. But I think in this case we provide enough evidence that not only statistics counts, but the absolute data and the combined clinical effect is remarkable, and there is no doubt it's going to be making a difference and establish a new standard of care.
Palbociclib is FDA approved right now, and some clinicians are using it in their patients.
I think the majority of clinicians in the U.S. are using it. Sometimes, especially early on, physicians felt that because this was a drug that was a little bit more potent than standard endocrine therapy, they could delay the use of this drug, but I think this data strongly recommend against it.
Well, that's another question I have. So in this particular group in the clinical trial, these women had advanced forms of breast cancer. Could this drug be used early on?
Yeah, that's a good question. In fact, the drug is being tested right now in women that have completed surgery and they are receiving adjuvant therapy. And the goal is obviously to prevent that resistance that brought these women to need a drug in the advanced setting. So the idea is if you have a very effective drug in the metastatic setting and you move in the early setting, probably you can reduce the number of metastases that develop. And that will be even more important and contribute even more to reduce the death of patients for metastatic breast cancer.
This was an international study, correct?
Correct.
So they had sites all across the world.
All across the world, there were 144 investigators all over the world. So it means also patients participating all over the world. I think we are very excited to be leading these studies and, of course, to see these results. Interesting enough, sometimes the access to the drugs is not available across the rest of the world always at the same time. But I think this data would be even more compelling for that healthcare system that cannot afford to approve this drug.
What typically happens in the medical community when results like this come out?
Of course, we are excited about what we have, but we are not satisfied because there is still a fraction of patients that eventually progress even through this treatment. So we're trying to better define what additional treatment we need to incorporate in the management of this patient with advanced breast cancer. We want eventually, if possible, at some point to eliminate chemotherapy. And in order to do that, we need to better study the biology of the disease, what these resistant tumors really are about, having new drugs to effectively block these resistant pathways. And as I say, hopefully this management of breast cancer will become the management of a chronic disease that women can live for a long time without major side effects, without having to really be too much concerned about what's going to happen to them tomorrow, especially these young women that we are treating right now.
So you're actually an international expert on the treatment of patients with inflammatory breast cancer, which is a rare breast cancer that may present differently than a lump in the breast. Tell me about the symptoms of IBC and how your patients do with treatment.
I'm glad that you are giving me the opportunity to speak about inflammatory breast cancer that is considered usually rare, but I think all the statistics suggest is also misdiagnosed. And the reason being that these women wake up in the morning with a swollen breast and skin changes in the breast. And because this happens so rapidly, the first diagnosis is a mastitis, an infection. So they get treated with antibiotics. The problem is they go to primary physician, they go to OB/GYN physician, and they don't know about the disease. They think it's a mastitis, and sometimes these women get treated with antibiotics for a long time. In reality, they get eventually to the point where they do a mammogram, an MRI, a biopsy, and they find out that they have a cancer. This cancer never is an early stage. It's always at least a stage 3, and 40% of the cases can be a stage 4. So you understand if your diagnosis is delayed, there is a higher chance that you have a stage 4 disease. So these are tumors that are extremely aggressive. They cannot be treated with surgery up front. They need to receive chemotherapy or definitely combination systemic therapy in order to reduce the size of the tumor and improve the skin. They need to have a mastectomy all the time because the skin is involved and there is no lump most of the time. And then they need to do extensive radiation on the chest wall. They need to continue treatments in the adjuvant setting and sometimes for a longer time. In spite of giving standard therapy, a good number of them had a progression in the first 2 or 3 years. When it comes back, it comes back on the chest wall, skin rash, lymph node, organs, bone disease, sometimes brain metastasis. So there is a need to understand better why this happens. I think there are a few centers in the U.S. and other international that are studying this disease now for quite some time. There is not much funding, and there is not much talking about it. There is not much education. We still see patients that either are misdiagnosed, they had a delayed diagnosis, they have a recurrence because they did surgery that was not appropriate, they didn't receive enough radiation. A number of situations that certainly contribute to make the life of these women even worse. And usually they are younger than the others.
They seek you out from all over the world. Do you get phone calls, emails, messages from women who are recently diagnosed with this?
Yes, correct. We do have also an IBC international consortium with a website, and we try to make sure that we coordinate the research and also the clinical trials if possible. And because they know who are the experts or where they are, so we receive a number of we see a number of patients. My clinic is enriched with inflammatory breast cancer patients, and we try to help as much as possible.
What can you tell physicians, OBGYNs, primary care physicians to look for to spot this early? How can they help you treat these women?
So the first fact to consider is this is not a skin problem. It's a breast problem with some skin rash, and skin changes are very well described and usually happens very frequent. Mastitis is a medical condition, happens when women lactate. So if you have a postmenopausal woman that has no sign of infection, there is no reason to think about mastitis. So you should refer to a breast specialist at least to do some additional workup. Sometimes because there is not mass, the mammogram not only is uncomfortable, but also doesn't see what the disease problem is. So usually an MRI is the best imaging tool. So be suspicious, I think, for every physician that see a woman that comes to their office complaining of a swollen breast and a red breast, and has no other reason to have that factor. Think about inflammatory breast cancer. This is a breast cancer without a lump, and is not considered properly in the context of what we recommend. Everybody talks about locally advanced and not inflammatory. Inflammatory is a different disease. Locally advanced is the one with a lump, grows over time, can take months or years. This one appears very quickly. So try to make the appropriate workup, refer the patient where a specialist may be available. Don't try to manage if you have never seen. And unfortunately, we see also breast specialists that have never seen in the community especially. I think this is like, imagine leukemia. You will ever manage leukemia in your office? Probably not. So don't try to manage inflammatory in your office. Try to send to referral for appropriate workup.
Is there anything else you would like to add, especially this being October? There's so many symposiums and conferences taking place.
I like to have a dedicated breast month, but I really think that we need to continue to focus on breast cancer, health, quality of life, and drug development all the time, because that's what our women, our patients need.
Read more about Dr. Cristofanilli's research at feinberg.northwestern.edu.